Thank you very much. Mr. Chairman, ladies and gentlemen, it's my pleasure to present this poster on behalf of Dr. Henry and all the other authors of this paper. Basically, what we're talking about is there is an unmet need for people with type 1 diabetes, as more than 50% of people with type 1 diabetes are obese, and about 2/3 of them have a hemoglobin A1C level greater than 7%. So here what we did, it's a pooled analysis of the INTANDEM-1 and the INTANDEM-2 trials. And the purpose of that was to evaluate the percentage of patients who achieved a hemoglobin A1C of less than 7%, no weight gain, and the percentage of people that achieved a hemoglobin A1C reduction of equal or greater than 4.5% and no weight gain. So this is the trial design that had been presented before. Basically, just to recap, the INTANDEM-1 was the study that was done in the US. The INTANDEM-2 was done in Europe and in Israel. There are almost 800 patients in each one of the groups. So following an optimization period, and there was a committee that was actually looking at the optimization of insulin, the patients were then randomized into 3 groups: the placebo group, the Sotagliflozin 200 milligrams, and the Sotagliflozin 400 milligrams. It was a 24-week initial study, followed by an extension up to 52 weeks, and afterwards there was a 30-day safety follow-up. Just to look at the baseline characteristics again, nearly 800 patients in each one of the groups. They're very similar in terms of proportion of men and women. In the INTANDEM-1, this was done in the United States, so people have a slightly longer duration of diabetes for about 25 years. The baseline hemoglobin A1C was about 7.5. They were more obese than the European population with a BMI of 30, and about 60% of them were on pumps. Compare that and contrast that with the INTANDEM-2, in which patients were a little bit leaner with a BMI of 28, hemoglobin A1C slightly higher, 7.7, 7.8, but only about a quarter of them were on insulin pumps compared to 60% in the US population. So this was the pooled analysis. And what we see here in the first panel, 24-week reduction, 52-week reduction. We are looking at the reduction of hemoglobin A1C after optimization of the insulin. So we still see here represented in green Sotagliflozin, 200 milligrams. There was still a reduction of 0.36%. And with the higher dose, the 400 milligrams of Sotagliflozin, a reduction of hemoglobin A1C of 0.38%. After week 52, the reduction of Sotagliflozin 200 milligrams was 0.23, and the higher dose 0.32. And we see here the changes in absolute weight. In the upper panel, we see the TANDEM-1. We can see reductions of weight of almost 2 kilograms with the lower dose, slightly over 3 kilograms in the higher dose. Compare that with a weight gain of about 1.2 kilograms in the placebo group. And these changes were highly statistically significant. Now looking at the INTANDEM-2, we see similar results with a reduction of hemoglobin A1C at the end of 52 weeks of 1.88% with the lower dose, 2.63 kilograms with the lower dose, with the higher dose, and with a weight gain of 0.3 kilograms in the placebo group. And what I'd like to point out is that about after week 16, the numbers remain pretty much stable in terms of the weight loss, and it just continues throughout the duration of the trial. Now looking at the pooled analysis of composite endpoints at week 52, we are looking initially here at hemoglobin A1C reduction of less than 7 and no weight gain. Almost 22% of patients on the lower dose of Sotagliflozin achieved that dual point of reduction of hemoglobin A1c to less than 7 and no weight gain, and just over a quarter of the patients with the SOTA 400 milligrams achieved this dual endpoint. Looking at hemoglobin A1c reductions of less than 7% and no severe hypoglycemia, the numbers 26% for the people on the lower dose, almost 30% for the higher dose of sotagliflozin, almost twice as much as the placebo. And if we are looking now at the triple composite of a hemoglobin A1c of less than 7, no weight gain, no severe hypoglycemia, it's about 20% with the sotagliflozin 200 and about 25% with the higher dose. And now looking at the quadruple endpoint, patients that achieved a hemoglobin A1c of less than 7%, no gain, no severe hypoglycemia, and no DKA, we are talking about 20% with the lower dose, 25% with the higher. And now if we are looking at the treatment difference in patients that achieved a hemoglobin A1c reduction of greater than 0.5% and no weight gain, it's almost a quarter of the patients with sotagliflozin compared to 8.8% of the placebo group. Now looking at hemoglobin A1c reductions of greater than 0.5%, no severe hypoglycemia, about a third of patients. And now looking at hemoglobin A1c reductions of greater than 0.5%, no weight gain and no severe hypoglycemia, we are looking about just over a quarter of the patients reach that triple goal. And for the quadruple goal of reduction of hemoglobin A1c of greater than 0.5%, no weight gain, no severe hypoglycemia, and no DKA, we are looking at 21% and 27%. Now, analyzing the adverse events, the main adverse event was DKA that was observed in one patient in the placebo group, 15 patients in the sotagliflozin 200 milligrams, and this is out of a total of 524, so percentage-wise it is 2.9%, and for the sotagliflozin 400 milligrams, there was 3.8%, 20 patients out of 525. Severe hypoglycemia, if anything, numerically was lower than in the placebo group. The other side effects, as we've seen already discussed previously, diarrhea, genital mycotic infections, but very few of those led to actual discontinuation of treatment. So in conclusion, even after insulin dose was optimized, there was still an obvious reduction in the hemoglobin A1c levels, either by the criteria of looking at less than 7 or a reduction of greater than 0.5%. And there was a lower incidence of severe hypoglycemia in both groups, patients with on the 200 as well as the 400 milligrams of sotagliflozin. There was a higher incidence of DKA, class-related, of course, but overall patients did very well, and it really was a pleasure being part of this study because it's absolutely amazing how well the patients did clinically, and the patient satisfaction was really a very important factor. So thank you very much.